Veil-sparing technique for anatomical endoscopic enucleation of the prostate is a versatile technique that was initially described in holmium laser enucleation of the prostate. However, its stepwise approach is adaptable using any type of energy. Herein, we present lobe by lobe bipolar enucleation of the prostate using Hermann loop. The first eye is inspection of the prostate anatomy, followed by prostate incision starting at the deepest groove at the bladder neck. The aim of this incision is to create a working channel or trough from the bladder neck to the apex, allowing free flow of the irrigant. This incision is extended in J shape, following the apical bulge of one lateral lobe. The distal end of this incision is limited to the mucosa. Then bluntly assisted by the peak of the scope and blunt-tipped loop, the anatomical plane is developed. Progressive dissection through the plane is continued both bluntly and sharply. To start the apicolateral dissection of the adenoma, the scope is flipped 180 degrees. With flipped scope and loop facing up, the mucosal distal attachment of the adenoma to the sphincter is cut sharply and transversely. A proximal inclination within the adenoma is acceptable to maintain a good mucosal veil covering the sphincter ring and to avoid mucosal stripping off the external urethral sphincter. The dissection showed start from the created plane towards the anterior commissure. Anterior commissurotomy at 12 o'clock position starting at the bladder neck and deep to the capsule is performed and medially deepened to join the laterally created plane. Anterior dissection is continued from the apex towards the bladder neck. Bladder neck dissection continues in clockwise manner from 12 to 2 o'clock position. Using two kinds of movements, rotating and pulling back movements, a C-shaped basolateral dissection is performed to ensure complete lateral dissection of the adenoma base from the capsule. At this stage, the adenoma is completely dissected and separated from the surgical capsule apart from his base posteriorly at the bladder neck. It is ready for flipping inside the bladder in preparation of detachment. Similar steps are repeated in the contralateral lobe. Adequate hemostasis is mandatory to ensure good visibility during morcellation.